ACAP, and you've joined the ACAP Vendor Education Call. The purpose of the ACAP Vendor Education Series is to allow our preferred vendors to share their vast knowledge on topics that are of interest to ACAP Health Plan members. This call, like all ACAP calls, will be conducted in accordance with our antitrust guidelines, which can be found on the ACAP website at www.communityplans.net. The focus of the call today is Asthma Management, a case study of HealthNHand. And we are pleased to have presenting today Sheena Cherian, PharmD Manager, Drug Therapy Management at PerformRx, an ACAP preferred vendor, and Amos Adler, President and co-founder of Memotex. During the call, you can ask a question at any time. You can do that by typing in the question in the chat box in the question box to the right of your screen, and then just hit send. And all questions will be answered at the end of the call. We also want everyone to know that this call is being recorded and will be posted along with the slides on the ACAP website. For your information, a link to the slides in the recording will also be sent out to everyone who attended the call. So at this time, do you have anything to add, Ron?
No, I think we're ready to go.
Great, then I'm going to turn the call over to Sheena and Amos.
Excellent. Well, thank you very much for the opportunity to speak to you today. We're really excited to be able to talk about some of the great results that we've been having from this intervention that we built together with PerformRx. Again, my name is Amos Adler. I'm the founder of Memotex. And we are a company that focuses exclusively on adherence interventions, building digital health interventions with the focus of improving patient adherence to various types of treatments. All of our programs are in general condition-specific or population-specific type of interventions within a number of different verticals, including manufacturers, health plans, PBMs, providers, and academics. Our whole focus really relies on a methodology, an algorithm set, and a communications platform that allows us to build very targeted communications based on multiple sources of data to ensure that people are adhering to a treatment regimen. We have a flagship JAMA-published study that we conducted in the glaucoma space with Johns Hopkins University. We have a number of different validated clinical and commercial outcomes that we can talk about, and here today we're here to talk to you about our fabulous study that we did with PerformRx. So just to quickly speak about adherence and the impact that we have on outcomes, this is a small graph that shows the correlation between adherence and improvements in outcomes. And we all know that there are a number of different business benefits that are associated with improved adherence. In the case today, we will be talking about some of those benefits in an asthma setting, but this is just to show that there is clearly a correlation between adherence improvements and the outcomes and costs that are associated with those. So this slide is really sort of the meat and potatoes of Memotex as a whole. Really, Memotex is built on a few things. Primarily a series of methodology, or a methodology that we have built over the last 6 years, which allows us to bring together stakeholder inputs and evidence-based inputs in order to create personalization algorithms that allow us to use multiple sources of data. And as you can see, the data types on the right-hand side of your screen, there are subjective data sources, things from patient self-report related to people's conditions, as well as objective data sources that allow us to create very powerful personalization of content to people based on, number one, how they are feeling, what their mental state is, what their understanding is, what their anxiety might be, and we combine that together with claims data or any refill data, and including any biometric data that we can use to personalize content to people based on their condition, their state, and their actual behavior. So those are the algorithms that we then use to create content, which we then distribute to people based on the communications media of their own choice. So patients can choose mobile, email, interactive voice response, or telephony-based types of interventions, or SMS text messaging. So we're able to then talk to people exactly how they want to be spoken to, and from there be able to interact with them on an ongoing basis. So this slide just shows some of the thought that we've put into the replicability of adherence interventions overall. This slide really speaks to, number one, the recruitment. How do we actually get patients onto adherence programs or digital support programs as a whole? And this is a variable. This is essentially variable in a way that we work with our partners to figure out the channels and the integration of adherence or digital support programming into clinical workflow and ultimately commercial workflow. Once we have people recruited onto a program, whether it be through a website, as you'll see in the case of HealthNHand, we have to do something with them. We have to speak to them, and we have to understand the content that we're going to use and the sequencing of that content over a period of time. We also have to measure that result so that we can ultimately show some ROI. And we also, as you can see, the personalization piece is where we start sprinkling, as we like to refer to, personalization into the mix so that we can ultimately extend the interest and the engagement of people within our programs and with their own health. This next slide really speaks to the methodology that we have developed over the last several years that essentially takes into account the evidence base, which is all the work that you folks have done to understand what the condition-specific behavioral barriers to adherence might be. So what does the literature say, and how are we going to understand that? And we combine that with a very rigorous stakeholder gathering process where we speak to the people on the ground, the healthcare practitioners, the case managers, the pharmacists, all the people that are out there speaking to patients, and we really try to bridge the real world with the evidence base so that we can then create, number two, questionnaires and assessment tools that we deliver at the beginning of an intervention and throughout the course of an intervention to help us then determine what content people will receive over the course of a campaign. The algorithm set allows us to tune and to shift the weighting of different types of content to people over time so that we're ultimately creating relevance and making sure that the intervention is having an impact. These are just some of the behavioral inputs, the subjective data sources that we get from people when we ask them validated questionnaires at the beginning and throughout the course of a program. And as you can see, some of these are highlighted. These are now speaking to the HealthNHand program that we developed in conjunction with PerformRx. And some of the items that we identified in our literature review and through the stakeholder gathering process involved the understanding of or identified the targets or the barriers to asthma controller medication adherence. Some of these were health literacy, patient beliefs, and some of the psychological and motivational barriers such as anxiety, self-efficacy, and really the effect of people's interactions with their health on their quality of life and their daily their daily interactions with their medications. Objectively, we use some other data sources here. As you can see, we use multiple data sources in a number of our programs that allow us to understand a little bit more about a patient from their claims data, from any other source of biometric data that we can obtain. And in this case, we started to understand things like the delays to refill, and we were able to use some of these elements, such as refill dates, so that we could schedule refill calls or refill text reminders, in addition to looking at the claims data so that we can understand behaviors in terms of how people use their rescue inhalers and the impact that we wanted to have on that. So ultimately, we wanted to also reduce the use of rescue inhalers in conjunction with the increase in controller medications. Part of this program that was very interesting to us was the use of air quality indicator forecasts that we were pushing to patients on an ongoing basis for the DC area that we obtained from airnow.gov. So we got a data feed that we then started triggering messaging and content to people, both related to their behavior so that we could keep them engaged, as well as air quality forecast information that would then trigger people to think a little bit more about how they wanted to use their controller medications to manage their asthma on an ongoing basis. And I don't know if you can really see it, but here you have an example of a text message that patients would receive that would have some links to additional information. This one also had a mood meter that allowed us to take the temperature of how people were feeling about their own mental state on an ongoing basis, and then we're able to feed back based on people's responses to those texts. Part of the program involved not only a text reminder, but the ability to communicate with people however they wanted to be communicated to, whether it be email, text messaging, or IVR messages. And the example of an IVR message, I'm going to play one for you right now. This is just a simple telephone call that somebody would receive on a daily basis. Not this one in particular, but every day would be a different type of message that was related to their own personal journey with their asthma medication. So have a listen.
HealthNHand here. It's time to take your medicine. We'd like to tell you about better controlling asthma triggers. Knowing what the AQI is ahead of time makes planning for tomorrow a lot easier. Being prepared is half the battle of managing your asthma symptoms. Press 1 if you have taken or are about to take your controller medicine. Please press 2 if you would like us to remind you again in 1 hour. Press 3 if you would like to speak with a HealthNHand representative.
So that was a simple example of an IVR call or a robocall that somebody would receive that's customized and tailored to an individual's needs at that particular point in time. So that's sort of my speech, my piece of the puzzle here. I'm going to transfer this over now to Sheena to continue and talk about some of the pieces of the design and results.
Great, thank you, Amos. As Amos had said, my name is Sheena Cherian, and I work in the Drug Therapy Management Department at PerformerX. And one of our primary responsibilities is to review patient profiles, and we do patient and prescriber consultations. And as you know, adherence is such a huge problem for many of our members, and a lot of the things that MemoText addresses, such as the psychological, motivational, health literacy, are all types of barriers that we've experienced to our patients' adherence. We know that there is no one-stop solution for adherence, and non-adherence has been consistent among most of our members. You know, we've tried calling patients, we've used interactive voice response, we've used pillboxes, we've even used pill station units, but there's always still an issue with non-adherence. While we've had some success with each of these different types of interventions, there were still members that really weren't being impacted. So we wanted to see other ways and different types of techniques that we could use to reach them. So we utilized technology as a platform to help those patients that we were not reaching through those conventional methods that I had stated earlier, and that's where MemoText had come in. We realized that every member was using their cell phones, right? Even when you look at now, wherever you are, patients are always on their cell phones. People are always on their cell phones. So why couldn't we utilize those cell phones for a health application? MemoText had developed this platform to send these text messages to members, and we thought that we could use those reminders to be whatever the patient wanted. So we liked that it was customizable for the patient, that the patient could personalize it for whatever they needed, and they could get the messages when they wanted it. Usually with the text messaging campaigns, users can respond to say stop when they when they wanted the messages to stop. But we liked the flexibility that when patients first enrolled into the program, they could say that they wanted the reminders to come day or night, or if they wanted it to come every day or every other day. So it was nice that it could be drug reminders, they could be educational, they could be informational, depending on what the patient needed and wanted. When we were deciding which patient population, we had a good partner with our AmeriHealth DC health plan, so we were able to choose asthma members that were over 18 years of age. We chose asthma as a population because it was such a large population for us that had such high costs for asthma-related ER visits and hospitalizations. And through our own drug therapy management program, we had seen that these costs were attributed to improper management and lack of adherence to their prescribed therapy. So it only seemed appropriate for us to target asthma with this pilot. We had then deployed HealthNHand, and as Amos had spoken about earlier, we had started with a website because we were really interested in just member engagement. When we started the pilot, we had chosen members that had a diagnosis of asthma, and we excluded those that had COPD. This was an opt-in program based on the state guidelines, which had made it difficult in the beginning since we had to find interested patients. So we found the asthma members, there was about 1,500 initially, but we wanted to maintain a control group. And then we had sent some communication out to the members in order to get them engaged. We gave them information about HealthNHand. We gave them information about their asthma, just to try to get patients to be interested in signing up. Initially, when we had first started, patients would get this information, and then they would log on to the website, and they would enroll themselves, and then, of course, choose what types of options they would want with their program. That was a little bit slow in terms of enrollment, and that's when we started doing more personalized outreaches to patients, and we really started to see more patients start to become interested in enrolling into the program. We outreached to them, we took down the information, we helped them fill out the initial survey, we helped them set up their program so that they would receive the text messages and exactly when they had wanted it. And that really helped for us to be able to engage the number of patients that we had received at the time. So our biggest struggle really was just getting a hold of the patients. As you know, in a Medicaid population, which is where we had done this pilot in, the patients many times don't have valid phone numbers, and they're a very transient population. So that was our biggest struggle initially. But once we got the patients enrolled and signed up into the program, it was really easy to get them to stay on the program and to be interested in it once we got a hold of them. As you can see here, we had about an 87.5% retention rate for patients. And then once they were enrolled in the program, about 72% of those patients were actively engaged with the program. So they were, that just means that they were filling out the surveys and they were responding to drug reminders. Every member that was enrolled into the program had completed that initial onboarding survey, and the results of the survey are shown here. Just a few tips or a few points that we had taken away when we had seen those survey results. When the patients were asked, is there anything else that you would like more information about, most of them had said that they wanted more information about asthma and the medications that they were taking. As the pilot had gone on, you see that there was a trending down because patients received survey questions throughout the pilot. So it would be at 4 weeks or it could be at 12 weeks that we were re-administering the survey. And you would see that the patients that were responding that they needed more information about their asthma was starting to decline because they started receiving more information while they were throughout the time of the program. So it was nice to see that they were starting to see some benefit from the information that we were providing to them. There was about 55% of the patients that had said that they were adherent to their medications, but as I'll talk about later, we'll see that the actual data had shown a little bit different to what the patients were saying, that not all of them were actually that adherent to their medications. And then there was 78% attributed non-adherence to forgetfulness. Once enrolled into the program, we had received different responses from patients, so they did have the opportunity to respond back when we had sent messages about their asthma or just drug reminders. And this is some of the actual text messages that we received back from the patients. Some of the feedback that we had received on the air quality information, some of the patients were saying, keep your good information coming in. And yes, I have taken my meds, thank you. There was some feedback on exercise. We were telling patients that even though they were asthmatics, that did not mean that they did not need to exercise exercise or that they couldn't exercise. So they were happy that they had gotten that information, and they wanted to take that information back and see if there was somebody that could help them get started with their exercising. Some other feedback was we would get information on side effects. So patients were taking back the information that we provided to them, and they would say that they would go talk to their doctor about side effects. When we had gotten that information, when a patient had stated that they were having side effects to that medication, that information came back to our PerformRx drug therapy management team, and we were able to consult with that patient and get them switched to another alternative. So it was great that we were able to immediately act on some of this information that we received back from the patient rather than waiting a couple of weeks or even a couple of months for the next time that they would actually see their doctor to discuss how their asthma was going. So one of the other things that we had seen was that a patient had told us that they had been wheezing a little bit because of the weather change. So again, that was another opportunity for us to help the patient with their flare-ups. If this was an opportunity for a patient to, for us to help the patient see how to use their asthma action plan, when they were having different types of symptoms, we were able to consult with the patient on that, as well as help empower them to take control of their own asthma and their own health, because maybe they didn't know how to utilize some of the information that they were receiving back from their prescribers. One other thing that I thought was really nice was some of the patient, one patient in particular had said that they were happy that somebody had actually cared that they were healthy. So they really did feel like somebody was in their corner, somebody was there to support them if they needed it. So it was nice to get that kind of feedback from patients and to know that it was more motivating for them and encouraging for them to start taking control of their health because they knew somebody was kind of helping out and watching over them. The outcome, based on the responses, some of the interventions that we have been able to make, we knew that this was helping members, but there were some more objective measures that we wanted to definitely look at. So the outcomes that we were measuring through this pilot were quality measures directly attributed to the HEDIS scores, as well as health literacy and quality of life. We had already seen an increase in health literacy from the survey responses that we were receiving, just because of the education piece, but we would see a better picture of this once the pilot actually ends. I don't know if I stated it earlier, but we had started recruiting members earlier on in the year, so it was around January. So we hope to get some more data towards the end of this year and the beginning of next year. Next, of course, was the ER and inpatient admissions. We set out to do this pilot in asthma because of the high cost of asthma-related ER visits and inpatient admissions. So we really want to see that this program had impacted those two items. And then we'll be able to, of course, pull that along with the financial data at the end of this pilot. We obviously wanted some preliminary data, and one of the things that we've been able to look at was controller and rescue inhaler usage. Initially, when we first started the program, we had bucketed patients into 3 different buckets based on their historical rescue inhaler use and controller inhaler use. And then we wanted to do that so that we could see what the change was from baseline for those particular patients. So the patients that were in the high bucket were patients that were utilizing their rescue inhaler very consistently, so they were filling it consistently on a monthly basis. Whereas patients that were on the lower end for their rescue inhaler use were filling it with several months in between fills. So that's how we started the bucketing, to just see where the changes would occur. And there was about 68% of the patients had fallen into the low rescue inhaler use, but 17% of the patients were in that high rescue inhaler use. And as the pilot had gone on, and as the patients continued to receive information throughout the pilot, the rescue inhaler use started to shift based on the more information that the patients were receiving. So those patients that had a historically high use of rescue inhalers, we started to see a decrease in that use over time as the pilot continued to progress. So as they were getting more information about their medications and how to appropriately use their medications, they were starting to utilize their rescue inhaler less and less. So it just suggested that people were using their rescue inhalers less regularly. And across the board, it shows that more than 50% of the participants had decreased their rescue inhaler use across the board, regardless of what type of users they were historically. On the flip side, we had also looked at the controller use, and we had also bucketed the patients into 3 different buckets with poor adherence all the way up to optimal adherence. And we were defining optimal adherence as over 80% adherence, whereas the poor adherers were, again, less than 50%. And so the patients, as you can see here, the patients that were poor adherers, as the pilot went on, they continued to increase their adherence to, it looks like it's almost 50% that these patients had increased their adherence over time. We see that the patients that were at optimal and moderate adherers also showed an increase in adherence as well, but there was less of a change just because they were better adherers initially when they had first started the program. So this is consistent with the survey data that we had received from the members stating that they know and understand what their medications were. They understand now how to better use their medications because now they were using their controllers more and using their rescue inhalers less. While we had positive results so far, there were still some learning points that we had as the pilot continued to progress on. And one of the things that we'd like to see is to be able to correlate both of these uses to some a decrease in ER utilization. As I alluded to a little bit earlier, one of the biggest things and one of our biggest struggles was initial enrollment of patients, just engaging the patients in general. Patients definitely needed an incentive to drive participation, and so we had realized that if we had started that initial outreach, maybe including our case managers earlier to be able to engage members, we would have had probably a better outcome initially when it came to engaging members. They really appreciated the personal conversation that we had with them, and it was almost like we were encouraging them to sign up rather than having just a mailer come into them and hoping that they would come to the website and sign up. One of the other ways that we thought would be a better way to obtain better phone numbers for patients was maybe to piggyback on an on-site community program. Now, this was something that we had tried to do, but the dates of when those programs were going on never correlated to when we were trying to enroll those patients. So that might be something that when we try a different program in a different population that we might try to do. After we had received some survey responses from patients, we realized that sending patients to a website to complete questions had defeated the purpose of utilizing text messaging. So we quickly remedied that initially by deploying survey questions over text messages. So we were able to better engage members. We had higher participation because of that. So we were glad that we were able to see that earlier on and make that change. We had also seen that patients had also liked immediate feedback. So one of the next phases of this program was to include pre-populated message so that for frequently asked patient inquiries. This way patients, again, see immediate feedback. If we say thank you or great job or whatever it is, depending on what they responded to, it just is another way to encourage the patients. But overall, we really had a pretty good experience with this program. We were surprised with the types of patient responses that we were getting, and it's definitely something that we'd want to expand just beyond asthma. As you know, adherence is an issue across the board for all of our members, not just asthma, not just diabetes. So there's so much more opportunity, and we're really happy that we've been able to try so many different technologies for our patients to see where exactly it would best fit among our patients. So that's all that we had in terms of this pilot and the case study that we had with HealthNHand. At this time, we'd like to open up the floor for any questions.
Okay, we do have several questions today. First one, do some plans actually provide the wearables and help members obtain the federally supported cell phones as part of these programs?
So one of the things that we had, one of the plans that we were working with had thought about utilizing a cell phone campaign where they would give free cell phones to the patient. Now that was one of the ways to combat having invalid phone numbers or not being able to engage members, and that was one of the things that we definitely wanted to incorporate when we would expand this to different populations. In terms of wearables, I don't know if Amos, if you would be able to answer that question in any other context.
Yes, well, not necessarily in the context of health plans, but we have some other types of clients where they are distributing both Fitbits and or other personal home monitoring devices, excuse me, that we can get data from. This is extremely valuable because as we can get more of that objective data, it creates even more power for the program. So it's something it's growing. It's still fairly nascent, but it's definitely growing.
Okay, our next question. In terms of content, are you focused just on medication adherence, or do you also address the asthma action plan overall?
So in terms of the content that we send to the patients, it is around medication adherence, but there is motivational messages that are sent to the patient. We also had specific messages about side effects. So we had information on the medications that the patients were on. So if they were experiencing specific side effects, we would give them information on that, as well as information on exercise. We didn't specifically give information on the asthma action plans overall because it could vary from patient to patient. So when a patient was having if they were stating that they were having issues, we did have information about utilizing their rescue inhaler first, but then that would be escalated up to a PerformerX DTM pharmacist, and then they would outreach to the members. So they would have a full consultation with a pharmacist. It wouldn't just be over text.
Okay, our next question pertains to retention, and the question was retention after what period of time?
So the pilot started, it was from January up until the end of September that we were showing that retention rate.
9 months.
Yes, 9 months. Thank you, Amy.
Okay. Did the members have to pay for the text messages that were sent forth?
No, they do not. And because this was a Medicaid plan, we would not be allowed to charge the patients for the text messaging, so this was something that they would not be charged for. When we first had the patients sign up on the website, one of the things that they had to let us know was if they had unlimited text messaging, because again, we wouldn't want them to have charges for those texts.
Okay, our next question. What type of ongoing monitoring was done with these patients?
We received a file feed of all the different responses that patients had to different survey questions. So this was part of our drug therapy management program process. So once we got information on the patient that required follow-up, we would do patient consultations, and then if we needed a prescriber consultation follow-up based on any feedback we received, we would consult with the prescriber. So for one of the examples that I had stated earlier, if a patient was having side effects to a medication or they weren't appropriately controlled because we saw that they were utilizing their rescue more than they should, we would consult with the prescriber to either add a controller medication, switch the controller medication, increase the dose of the controller medication. So we would receive files on a monthly basis, but then if there was anything that was responded, if a patient had a response that was out of the norm in terms of it wasn't just a thank you or it had more information about their medications, that would be escalated to us immediately by memo text.
Okay, back to the text messaging. If the patients did not have unlimited text messaging, how did you manage the costs?
So when the patients first sign up, if they don't have unlimited text messaging, we did not enroll them into this program at this time. We did give the option for patients that if they wanted to receive IVR calls or if they wanted to do email communication, they could be a part of the program in that way, but they wouldn't receive text messaging if they did not have unlimited text.
Okay, our next question. Were the providers notified that they were enrolled in this program?
As part of our DTM program, we send out communication to prescribers to let them know that they are enrolled into a DTM program. We didn't specifically send communication out to the providers stating that they were enrolled in a text messaging program. The providers all know that they are enrolled in a DTM program.
Okay. Next question. What was the implementation timeline for this project?
So the implementation included a collaboration between PerformerX and MemoText where we were creating the content for the messaging. So there were some pre-scripted suggestions, but we had made a few changes based on our population and the reading level that they were accustomed to. Because of this, implementation and testing took about 6 months before we were ready to deploy the program to enroll our first members. We then had ongoing communication to fix any bugs that may have appeared upon roll-up, and then we had weekly calls with MemoText to ensure that it was a seamless transition for our patients.
Okay. Next question is, how did you overcome HIPAA issues? Did they give consent for specific messaging, i.e. text, IVR, et cetera?
Yes, so when they went onto the website, the patients had to fill out those questionnaires and they also had to consent. So that's how we were able to get through HIPAA.
Okay. Well, it appears that that takes care of our questions for today. I thought I'd just wait for a second or two to see if any others popped up. But it doesn't appear to be so. So I'd like to pass it back over to Debbie.
Thanks, Ron. And I really want to thank Sheena and Amos for an interesting and informative presentation today. We at ACAP appreciate your willingness to share your knowledge and experience with the ACAP members. And this was great initiative to talk about because I know asthma adherence is a huge issue for our plans. Before I say goodbye, I wanted to remind everyone on the call that the slides and the recordings will be posted on the ACAP website within the next few days. So I hope everyone has a pleasant afternoon, and let's say goodbye at this time. Thank you.
Thank you.
Thank you.